Okay, everyone, home stretch. This is very exciting for me and for us because this is the first time I'm presenting any results from the ECD registry. One thing that I really am proud of is that I gave literally this exact set of slides to the doctors yesterday. So I think that if a research presentation is completely the same between the doctors and the physicians, then we're doing something correct. So I'm going to tell you about the way that the ECD registry works. I'm going to tell you a little bit about how enrollment is going to date. I worked with you, the patients, a couple years ago to create like a symptom scale, like a tool, a survey which is specific to Erdheim-Chester disease. And then I'll tell you about some of what you have taught us, I should say, about quality of life for you guys and other what we call patient-reported outcomes. So the registry, so it's a longitudinal, meaning it goes over time, and it's observational, meaning I don't do anything to you, study of ECD patients. We get clinical information, radiologic information, and biopsy information. That's all the stuff that we get from records, scans, biopsies. And alongside that, we get what are called PROs, patient-reported outcomes. That's surveys that you guys complete. It's housed at MSK. That's where the study lives, although people can enroll from anywhere, and you don't have to be an MSK patient. In fact, half of the people enrolled are not MSK patients. For what it's worth, we have a sort of a sister study in the UK at Newcastle, where Matt Collins, who is up here, is doing the same thing with the ECD patients in the United Kingdom. So why do you have a registry, right? The point is to collect, the highest quality and thorough information about patients with a rare disease, because if people's care is scattered in various places, you don't get a critical amount of information to actually learn things and draw conclusions. So we want to learn as much as we can about all these different features of ECD, and this is all in service of trying to understand what treatments are better and in what ways and why. This is really supposed to be a resource to the entire patient community and the research community, and there's a particular focus on symptoms, quality of life, supportive care needs, and those are things that I don't assign values to. Those are things that you guys report yourself. So just so you get a sense of what's done on the clinical data end, so we collect records for enrolled patients. It's easier if they're seen at MSK, that's just printing notes, or we collect records from outside, and we collect very documented, comprehensive information about how patients they presented, what their symptoms were, what were clinical findings, what were findings on scans, labs, gene mutations, all that kind of stuff. And then we collect information about what treatments people had and what worked and how that was defined. And if people continued treatment or if they didn't continue it, is that because it didn't work or because they couldn't tolerate it or for what reason? We collect data at the time that someone enrolls, and then there's follow-up 6 months later and then annually to follow. But since there's a particular interest in the effects of treatment, if someone changes their treatment, we sort of reset the clock and collect information 6 months later because we have an interest in understanding what has changed when treatment changes. So if someone changes treatment and you don't check in with them for a year, there's sort of like a lost opportunity there. So the clock resets if treatment changes. Scans are reviewed by, we have there's a specialist who is both trained in PET interpretation and body scan interpretation who goes through the scans and documents sites of involvement, what parts of the body are involved. And there's a neuroradiologist who looks at all of the images of the brain and the spine because that's really its own specialty. The scans are treated as though someone joined the study, which is to say that we designate target lesions, which is a few tumors that are considered representative, and then those are measured specifically, either intensity of the PET or width on a CAT scan or an MRI, and then when follow-up scans are looked at, those target lesions are evaluated. That's the way things are done in studies. Not every single lesion in someone's body is measured, but a sampling is done, then those are what are looked at over time. And this is to remind me to tell you that the sending slides, it's not always easy to traffic slide material among institutions. There's an interest among hospitals to keep pathology material for themselves, and that's completely legitimate. If people can send the slides to us, then we can review them, confirm the diagnosis. Actually, we can make a digital copy of the whole slide and then send them back. So that we get to keep a record, and it goes back to the institution. Impact is our gene sequencing testing on ECD tissue, which tests about 400 genes to look for gene mutations. BRAF is one, but there's many others. And that is something that we can offer to any ECD patient anywhere, actually regardless of the registry. That's something that we have a program to offer. And then there are various tests for gene mutations on the blood, not even on tumor, and those are kind of almost ready for prime time, but they're very exciting. There is this, there's a software called REDCap, which is how all of the data is entered, whether it's actually, if any of you have done the surveys, you do those on REDCap. It's pretty user-friendly and easy. And actually, the clinical data is done through the same web-based platform, and that allows the clinical information and the information from you to sort of be looked at together. The data for the registry is not restricted to me. This is something that is governed by us and the Global Alliance together. And if another researcher wants to look at the registry data, we create an agreement, a data sharing agreement, and then we can sort of design a project, and then I can send them de-identified information for them to do a study with the registry data also. So this is a resource for everyone. So patient-reported outcomes, Jean mentioned these. So these are, this is something that is becoming more relevant for clinical research, particularly for rare diseases. And these are surveys and questionnaires that allow patients to express things that are important to them, symptoms, quality of life, in your terms, not in what someone rates about you. And the goal of this is simple. This is so that we can make the things we do for you more responsive to you, and more responsive to you and your family and your goals and values. And for rare diseases where you're dealing with small sample sizes, when the statistics are such that you may not always show very significant changes in scans, but you can augment the way that you demonstrate a treatment works if you can demonstrate that you improve the way people live and symptoms in measurable, rigorous ways. So there's an interest to, particularly in rare diseases, to develop PROs that are meaningful and that you can believe will show that a treatment is effective. The creation of our set of PROs, I did not make them up. We did a bunch of focus groups, some of you may have been in them actually, in 2015 in Houston. That's where the ECD meeting was then. So we did focus groups and we did subsequent conference calls. And the goal at the time was two things. One, we wanted to sort of brainstorm what are the symptoms caused by ECD? Because one patient may have some because of the way that their body is affected. Someone may have a totally different set of symptoms. And let's brainstorm and think about what is the list, capital T, capital L. What is like the superset of possible disease-related symptoms? And then we wanted to think about what are the kinds of ways that ECD affects your life, so that if you're going to collect this information over time, what are we going to look at that if it changes will mean something? So this is the list of surveys. So there's this ECD symptom scale that I'm going to tell you about. There's an overall quality of life measure. The group felt that pain and fatigue, even though those are included in the symptoms, are both so common and important that they sort of deserve their own dedicated measurement. Anxiety and depression, supportive care needs, you'll see what that is, and then a separate scale for not just disease symptoms but side effects of treatment, and then a measurement of just daily functioning. What kinds of things can people manage and not manage? And these responses are obtained at the same time points as the clinical data is gotten, so that those are collected at the same time. So this is a little schema of how we made the symptom scale. We did 3 focus groups of 8 patients, 8 participants each, because it was a mixture of patients and family members. In the methodology world, that's the number of people that you have a rich discussion, but it's not too many. There's people who sort of design the methods for this kind of thing. And we sort of discussed a list of symptoms, then we offered sort of a list of symptoms that like I had come up with, that was many fewer than you had come up with. And then we kind of worked together to refine like the list. And the point of the list was every item on that list was something that someone in the room had, right? So there was nothing extraneous. There was no symptom that was unaccounted for, and also there was no item on there that everyone in the room was like, that doesn't apply to me. So this, when you do this several times, this is, you saturate is the methodological word you used. So then you have kind of saturated the discussion, and then you have a believable sense that this is the authoritative list to think about. And what the discussion the group came to was that we want to have one way of looking at symptom severity, how bad something is, and that's different from how frequent it is. And you want to be able to talk about how severe it is and how frequent it is, because those can change, but not always in the same way. And so I'm going to show you the results of the symptom scale, which I think you'll find very interesting. So thus far in the registry, we've had 91 people enroll. 60 have completed surveys, which means that 30 have not. And if you're in this room, I want you. And then about 20 have done a subsequent time point. So what I decided to do for this meeting was to stop at the first 50 completed sets, which, for you guys know, for a rare disease, that's not a small number. Of the 50 people, the age in the middle was 56, and the range was 18 to 77. And then you can see the breakdown on the screen here. And about half of the respondents so far are MSK patients. And we do look at things like employment. So half of the group is employed, 28% is unemployed, and 20% are retired. This is just for you to look at, because this is representative of you. This is the different parts of the body that are involved. And then this is the different treatments that people are on. In the upper right, it's sort of broken down in a more particular way. On the bottom, it's a little broader. So about half of people are on targeted therapies, BRAF inhibitors, MEK inhibitors. About a fifth are on some kind of conventional treatment, immunosuppression or chemotherapy or interferon. And then actually about a fifth are not on anything right now, which was a surprise to me. So here's one of the punchlines. So this is, we grouped the symptoms into different categories. So this is neurologic or psychological symptoms. And of the 50 people, 48, meaning 96%, reported at least one of these. And so the most common was trouble with memory. Half of the participants reported memory problems. And then if you sort of let your eyes wander down, a lot of challenges with mood, stress, anxiety, and then balance, coordinating the arms and legs, but a lot of things related to psychological challenges, being short-tempered, discouraged, that kind of thing. So this was very eye-opening to me, how very frequent symptoms like this are. Then the next most common set was what we call generalized symptoms, things like fatigue, night sweats. But interestingly, there's a big predominance of loss of sexual interest, almost a third of the group, And then urinary problems, difficulty sleeping. So just a very big preponderance of a lot of different kinds of problems that you guys face. And then some what we call gastrointestinal symptoms, dry mouth, diarrhea, abdominal pain. These are all very common. And then 56% report aching bones or joints, different kinds of pain, muscle pains, vision problems, and then breathing problems. So this is a very complex figure, but it contains a lot of information, so I'm going to explain it to you. So everyone ranks 5 of their most severe symptoms. So I'm going to walk over and do this. So everyone indicates their most severe, and then second, 3, 4, 5 of their symptoms. So this is for the most severe symptom for the group. And so for that worst symptom, for 48% of the people, it was neurologic. And then a quarter of it was constitutional. And so if you look here, what this tells you is that for the most severe symptom to the least, about 3/4 were neurologic, psychological, or some of these generalized symptoms. So, whether it's the most severe or less, these are really what people are dealing with about 75% of the time. And then this is the proportions of frequency. So for the most severe symptom, it was almost constant for half. And then the frequency goes down somewhat, but even for people's least severe symptom, it's either constant or very frequent. So, what this tells me is that there's a lot of these sort of neurologic, psychological, constitutional symptoms, and that they're quite frequent, even when they're not as severe. And then this is a score that's out of 10. So for people who reported pain, the average score was a 5 out of 10. This is treated people, not untreated people. So this is how well people are feeling when they're on treatment. And then the average fatigue score was 5 out of 10. And again, that's people who are on treatment, at least 80% of them. So, we're not doing the best job. About 26% of the group had some kind of depressed mood. This isn't just someone who ticked a box, depressed mood. This is someone who did a certain kind of survey, and based on their score, meets criteria for this. So that's why that number is less than the people who ticked off the box once. Likewise for anxiety. In terms of, you look on the bottom left, these are different kinds of functions that people thought were impaired. So everyone's fine using the phone. No one wants to do housekeeping. But people can shop, right? Okay, I'm just teasing. But these are the functional impairments that people reported. This here on in the orange, this was a powerful message to me. So I'll translate it for you. So this is an overall quality of life score, and so the average for the group was 69. The maximum is 108. That's just how the scale works. And so this scale has been implemented across hundreds and hundreds of people with cancer. And so what you can do is you can say if you take 1,000 cancer patients and you take that number, what is the average functional state of that person, right? So what does that number mean, right? So 69 is about what you would see for a cancer patient spending 50% of the time in bed, which is like a very, very diminished quality of life. And you're the least surprised to hear this, I know that. And if you look, that's broken down into different categories. So that's across things like physical well-being, social well-being, emotional and functional well-being. This is a different survey where people indicate what are the kinds of things they would need greater support with. And I put bold for some things that aren't really captured by some of the other things that we looked at. So a lot of people endorse feeling uncertain about the future, feeling loss of control, trying to keep a positive outlook. One thing that was very interesting to me is a lot of people have information needs about that they don't feel like they've received enough information about their condition, about their treatment, being adequately informed, being treated like a whole person and not just a case. So this is all stuff that we need to do better. I have an interest in ECD caregivers as well. So I'm sure some of you have done these surveys for me. So this is just 14, not 50. I am going to be opening a dedicated ECD caregiver sort of companion part of the registry next year. But what I learned from these 14 is that there's a great need for information, for support, for how to deal with the way that the illness has changed the patient and the whole sort of family structure. There's a lot of problems with anxiety, sadness, worry, feeling drained. There's this term in this literature called burnout. Yet, I think this is kind of inspiring. If you look at the bottom right, 80% or more reported that they find meaning and purpose in being and caring for someone with ECD, and I thought that was very moving. I think that doing these PROs with you really revealed to me a very wide array of symptoms and issues that you face that I think was unappreciated, although not surprising, especially to you. There's probably a particular burden of neurologic issues, psychologic issues, and those are related to diminished quality of life. Yet there's a great effort that you guys put through to maintain your function. And I keep reminding myself, I keep saying that you guys are treated. These aren't challenges facing someone who's not on treatment. So in some ways, this points to the opportunities for us to improve your treatment. If I wanted to compare, what about quality of life in people on drug A versus drug B? Right, we didn't get there at all. Or what about neurologic symptoms in patients with brain disease, treatment A versus treatment B? So you can't do that with 50 people. Like, you need more just to be able to have a comparison that's meaningful. So that's why I need greater enrollment. And this at least raises the question of whether things like this should be part of routine clinical care. Should you complete some of things like not a whole 45-minute battery, but should we be getting this information every time someone comes to the office as additional feedback for how someone is doing? So I hope I have convinced you that this is meant to be responsive to you. It's certainly supported by you. The most key questions about really comparing treatment strategies requires more people to enroll. And I think that participation across the community is really important. And I'll mention again that there's a caregiver study. And my email is right there. And there's a dedicated email address for the registry study below. And this is our whole team.